Good afternoon. It is absolutely my pleasure to be here and to speak to you about a topic that is extremely important, kidney support therapy for the smallest children. What are the options? Voy a platicar sobre la terapia de reemplazo renal aguda en los recién nacidos. ¿Cuáles son nuestras opciones? Here's my potential conflict of interest. Importantly, I'll be speaking about machines made by some of the people that I consult with, and I will be showing pictures of children that I've taken care of. The parents have given me and have encouraged me to tell their stories. So the objectives are to review the history of kidney support therapy in neonates, describe how new devices help us achieve the desired goals, and then describe some of the options that we have, specifically the new options on the new machines. And I will provide some epidemiology data on children that have been dialyzed with these small, newer therapies. So if we want to go back in time for a minute, we're going to remember that back in 1949, the first peritoneal dialysis procedure was performed. This life-saving therapy then expanded into 1950s for the use in children. And so now for almost 60, 70 years, children have been saved from acute kidney injury with the use of peritoneal dialysis. And there's reports from even back in 1955 describing the procedures using 10 to 15 cc's per kilo dwells, continuous hourly cycles. And this therapy is simple, it's practical, it's relatively safe and easy adapted for small children. Over the 1960s through 1980s, there was new pediatric nephrologists such as Steve Alexander, who's depicted here, who speaks about how they adapted these, and they got pretty good at it. They were able to take care of a lot of babies in different clinical care settings, like the cardiac intensive care unit or the pediatric ICUs. But he will tell you that it was often inadequate to meet the needs and the goals that he had for the patient in caring for them. And frankly, it was also felt that this was very boring after a while. And then in 1985 came this patient who in Vicenza, Italy, Dr. Claudio Ronco took care of. This is the first reported continuous AV hemofiltration treatment in the Bortolo Cologne Hospital. You'll notice there's no machines here. There's the filters right here in the bottom of the screen, and the baby's pump the baby's heart is used to pump the blood out, and then it returns back to the baby. So depending on the baby's blood flow, the amount of blood going through the system would change. They would adjust the height of the bags to determine how much fluid came off the baby, and they would sometimes replace fluid if more fluid was coming out than they wanted. Hence the term came replacement fluids that we still use today in our CRT devices. Other people besides Dr. Ronco performed these in the mid 80s. This is again Stephen Alexander's paper where his group described 5 neonates that they took care of with continuous AV hemofiltration. And then in the 1990s and 2000s, many people started to adapt different pumps or flow regulators. This is an example of how people did it in ECMO, where they would attach it to different systems in different areas, and they would have these pump regulators to either provide dialysis fluid in a countercurrent manner or replacement fluid to replace ultrafiltration that they had with, again, these regulators pulling the fluid into the effluent bag. And many of us continue to use these types of processes and these types of systems in ECMO even today. In addition, in around 1995 came about a new integrated system called the Prisma that was able to have multiple pumps on one platform, providing both blood flow, ultrafiltration, as well as dialysis and replacement pumps. And this, using this machine, several people, including Jordan Simmons, who's the primary author, Stu Goldstein came together and they did a retrospective study of several centers, 85 children with a survival rate of 36%, and their conclusions was that CRT was useful even in small children. The smallest one they reported was 1.5 kilos, and the outcomes at the time, 35% survival rate, was as good as other reported patients who were receiving CRT. In the 2000s, the PPCRT registry came out. This is a registry of approximately 14 hospitals, 400 or so patients, and I had the opportunity to dive into this data, looking at how CRT outcomes differed in those who were less than 10 kilos versus those that were above 10 kilos. And here we were able to show that the rates were similar to Jordan Simmons' paper, but the outcomes in those that were greater than 10 kilos, most of them survived. About 67% survived, whereas only about 40% of those less than 10 kilos survived. And the other thing we noticed was that the way we were prescribing CRT was very different in those who were really small, less than 5 kilos, versus those who were bigger, greater than 10 kilos, in how we provided blood flow and the anticoagulation and the effluent rate. And you can see here that the circuit life was very poor and different compared to those who were above 5 kilos. Moving forward in 2000s, new machines came out, and not only these two, but others came out that pediatricians started to use to provide critical care therapy. And with those machines, people started to report different types of outcomes in neonates. Here you could see, rates between 15 and 57% survival with these types of therapies. Again, these are relatively smaller cohorts. Interestingly, we performed a study called the AWAKEN study, the assessment of worldwide acute kidney epidemiology in neonates, where we really were trying to understand the rates of AKI across multiple neonatal ICUs. And the message that I want to tell you from this study is that of the patients that we had enrolled in our study and the ones that were in the NICU, only 25 of them received any form of kidney support therapy, whether it was PD or hemodialysis. Most received PD. And so this makes up about 0.5% of the population of NICU patients, which is much, much lower than the rates of use of kidney support therapy in adults or pediatric ICUs. And so perhaps it's time to change our mindset on which babies can benefit from kidney support therapies. And so I posed the question, well, why is it so difficult, and why has extracorporeal kidney support therapy lagged so far behind from pediatric and from adult world? And so one of the reasons certainly is that the equipment is technically very difficult to use in neonates. The axis maybe need to be too big. The filter sizes are going to be large compared to the extracorporeal volume. The calibrations and the scales and the accuracies are perhaps just not as precise as we need them to be. I think in addition, people have had bad experiences. And so if you've had things that happen where things don't go so well, you're not as excited to try it the second time. Certainly clinicians, especially the neonatologists, have very little exposure in their training to kidney support therapies. And many times CRT is only thought of, or has in the past been thought of, as a last-ditch effort. Not only did they have to, have very severe AKI, very severe fluid overload, but many times CRT has only been tried in patients that failed peritoneal dialysis. And certainly there's always been this argument about where this should be done. Is it best to move them to the pediatric ICU where maybe they have more experience, or is it better to keep them in the NICU, the neonatal ICU, where the nurses and the doctors may be more skilled and more comfortable taking care of small babies and the small baby problems that arise? And so the risk-benefit historically has not been very favorable. And you can think about your program, and you can think about, what are the challenges that you have faced in getting kidney support therapy to be provided to neonates. And it's very likely that these will come up for you. So moving into over the last decade, I'm going to talk to you a little bit in detail about Aquadex. It's the machine that we've been using in our program since 2013. I'm going to talk to you about Carpe Diem, which is a very exciting, very precise machine that's now approved throughout many places, many countries, including the United States. And the Nidus, I'm going to mention briefly, which is another machine that has been developed specifically designed for neonates. And to give you a timeline of this over the last 10 years or so, here's kind of what's happened. So this is in orange, you'll see Dr. Ronco's first publication in August of 2012 on the design of the Carpe Diem. The first in-human use occurred in September 2013. Case report was published in May of 2014. The European case series with 13 patients was published by Vidal in Blood Purification in 2019. It was FDA approved in April 2020. There was a report of 28 neonates across 6 centers that was published from Europe in Pediatric Nephrology in September. And then in the United States, the first case occurred in February 2021. When you look at the Aquadex, we performed our first case in December 2013 using the modified CVVH approach that I'll speak to you in a little bit. We published our first 12 babies in May of 2016. We performed a study with a couple other centers in October 2018. FDA was approved Aquadex for ultrafiltration only in children over 20 kilos in February 2020. Then moving on to the HF20. The HF20 is a small filter of 60 mils that can be used on the Prismaflex. It was approved in, it was first used in the United States in April 2016 and has been used around the world even prior to that. Got it FDA approval under emergency use authorization in August 2020. And then here in 12/2020, there was a publication of its use. The Nidus was first reported back in 2005, and that was performed in babies. There was a study that looked at in May 2014 of the first case series, and I just heard that there has been a completion of the initial iKid study that's looking at the usefulness and usability of the Nidus in, I believe, 5 or 6 centers across England. So when we think about what are the goals of care, it can help us think about the options of care, because really whichever option you choose should meet the specific goals of your patient. Broadly speaking, all these machines, peritoneal dialysis, hemodialysis, CRT, should allow you to achieve homeostasis. That's the whole purpose of kidney support therapy. We're not fixing the kidneys, we're just doing the job of the kidneys. And so there should correct and maintain homeostasis of electrolyte, water, and uremic toxins, and should allow you to provide as much nutrition, medications, drugs, and calories as you need to help your patient have a good outcome without causing fluid imbalances. But I think where some of these new novel devices come into play is their ability to limit problems, to minimize the risks. And so these smaller filters are allowing us to be able to do this therapy without as much blood exposure, without instability of hemodynamics, without access issues or less access issues, and without infection. And perhaps even more important than that, it's provided people who are less comfortable with these therapies just kind of a sense of calmness. It used to be that when we had a CRT machine in our NICU, all the attendings and the nurses and the families would get very nervous that this big bad machine was coming because of the bad experiences that we have. So certainly one of the goals and one of the things that you have to consider as you choose one machine or one therapy versus another is you should have something that's not going to freak people out. And so the options really go back to, what your goals are. You can either have an extracorporeal approach or peritoneal approach. You can do it continuously or you can do it intermittently. And each has its advantages and disadvantages. And to me, there are tools in a box that you may want to think about and pull out one tool versus the next depending on what your needs are. And so if you have a nail that you need to drive through a board, you can certainly grab a hammer because that's probably the best tool you have. If you don't have a hammer, you can certainly try to do that with a wrench. And so what are the benefits or the characteristics of peritoneal dialysis? It's certainly cheaper, it's easier, the catheter can be used, but ideally it should sit there and set so it minimizes leaking. You get some, but perhaps not every hour-to-hour control of ultrafiltration. And ideally, you would use it if you can't or you don't have the ability to do extracorporeal kidney support therapy. On the other side, the extracorporeal therapies are a little bit more expensive. They require more training, but they do have some extra advantages. One is you can have very tight hour-to-hour control, where 1 hour you may want 12 mils out, and the next hour you may want 20. You can use a catheter pretty much immediately after it's placed. There's no fluid in the abdomen that can cause GI and lung issues. And really, it's ideal if you don't have the ability to do PD. So which one is better? I don't think either are better. I think they're complementary. We need safe and effective options for kidney support therapy in these neonates. So today, besides peritoneal dialysis, we have the options of smaller filters, the HF20, that I'm not going to talk about much today, but it's 60 mLs, which is significantly lower than other filters that were previously available for CRT devices. The Aqueducts that I'll mention, the Carpe Diem and the Nidus. And the advantages of these smaller filters, these smaller supports, are that you can use lower blood flows, which allows you to use smaller catheters. And because you have a lower extracorporeal volume, you have a lower need for blood priming, and you have smoother initiations. And so, in my opinion, in our experiences, the benefit-risk ratios and the decisions to start kidney support therapy have shifted because of these advantages, so that now with lower risks, there's potentially more benefits for your patients. And so as we think about should we use hemo or peritoneal dialysis or a continuous modality, we have to think about multiple things: underlying disease process, hemodynamics, the size of the patient, what your goals are, and then the availability that you have at your center. So as I mentioned, in our program, we've been using the Aqueducts. This machine was approved back in 1995, and so it's been used now for almost 30 years. And what we essentially did is we took this filter that basically pulls blood from the patient and returns it, and pulls fluid as ultrafiltration, and we simply added a replacement fluid bag through a flow regulator to deliver fluids to the circuit. We wide in here at the axis a Y to be able to provide the heparin. And by doing that, we essentially are doing pre-replacement hemofiltration in a continuous approach. This system is important to recognize that their replacement fluid delivery system does not communicate with the console. And so if one pump were to not work, but the other pump continues to work, and they don't communicate, you can potentially see the potential problems that can arise. So it's very important, if you're going to use this system, to educate your entire team about this potential safety issue. And most commonly, this will affect you or your patient when you have access issues, because when you have access issues, you stop pulling fluid, but you continue to deliver the fluid at this time. So certainly for this system, but I would argue for any neonatal device, We have put together some safety nets. We weigh our patients twice a day. We do lots of education. The Aquedex machine has a hematocrit threshold that's designed to stop if the hematocrit rises too quickly. And we have very clear notification parameters to notify the nephrologist for low MAPs or for fluid discrepancies that the nurse is seeing. Now, what kind of babies are getting kidney support therapy? Well, certainly babies with acute kidney injury, fluid overload, sepsis, electrolyte imbalance. But we've, over time, have been taking care of more and more children with congenital kidney disease and uremia. And certainly inborn errors of metabolism continue to be one of the reasons that we dialyze babies. You'll find, or we have found, that there's lots of different types of babies, not only from their size perspective, but some are super sick. This is a baby that we took care of, was on ECMO at day 2 of life, and weighed 2740. Was one of the sickest babies I've ever taken care of in my life. This is the same baby now 3 months later, cute as can be, very, very, sociable, interacting with the world. Couldn't get peritoneal dialysis, and so was on continuous CRT, but still was able to get dressed in her fancy bows on a daily basis. And so in our program, you can see here the number of patients that we've taken care of in the neonatal ICU. We've reached 101 as of January of 2022. And you can see the number of patients that have received it for congenital kidney diseases versus those that received it for acute kidney injury over any given period of time. I want to walk you through a really interesting case that outlines the need for these complementary therapies. This is a baby who weighed 2970 at birth, had a prenatal diagnosis of bladder outlet obstruction and posterior urethral valves. On day of life, got very, very sick, intubated, placed on high-frequency oscillator, got placed on VA ECMO on day 2 of life, which is when they called us. So when we originally reached when they originally called us, I was not on call, but the nephrologist that was working that night basically made everybody stop and say, well, what are you talking about? We can't take care of this baby. This baby's on ECMO. It's got no lungs. The lungs have severe hypoplasia. It's incompatible with life. But after a lot of discussions with the team and the family, the team basically convinced the nephrologist that this was worth trying, that this baby was worth trying to save. Because of the new approaches that we had, the family and the team really pushed to make it happen. And so we agreed. This patient continued on ECMO, came until day 5 of life. On day 5, came off ECMO onto CVVH using the ECMO, using the Aquedex filter. Came off dopamine over the first couple of weeks. We switched out some catheters over the next couple of weeks. Had an abdominal problem, so we were not able to put a PD catheter, but was able to get a G-tube. Got septic a couple of times. Finally, we were able to get a PD catheter in this kid. This patient had very severe pulmonary hypertension that finally resolved and was able to come off of nitric oxide and sildenafil. This baby ended up being room 2, room air at around 5 months of age. We worked to get this baby home on peritoneal dialysis. And at 6 months of age, we were able to send him home to his family. Over time, this baby continued to thrive, was able to get off peritoneal dialysis at around 10 months of age. Had a problem. We had to pull the PD catheter, and he decided that his creatinine was just good enough and marginal to sustain him. He continued to do very well over the next year and got a kidney transplant at 3 years and 1 month of age. And you can see here the number of days on Aquedex was 151, 7 days on ECMO, was on the ventilator for a month and a half, 4 catheters, and is doing really, really well. This is kind of our numbers over time. You could see that if anything, our survival rates have increased. And if you look back and remember the survival rates of CRT and some of the other registries, they were kind of in the 30s to 40s range. So we're hitting at least those numbers or perhaps a little bit better. And in our program, what you could see is that we track this very carefully. The rates of hypotension at initiation are almost zero now. Only 2%, and those patients that have had hypotension, they usually get better with a sodium bolus or perhaps with a little bit of dopamine. This over here on the right, you could see how often our circuits last for more than 60 hours. 65% of them last for more than 60 hours, which is as good as we do in the PICU or cardiac ICU. This Aqueduct was published as a 3-center study with our friends at Cincinnati Children's and Seattle Children's Hospital, led by Shaina Menon. And we were able to pool 72 babies who were less than 10 kilos. The average time was 19 days of age at start. 4 kilos was the weight. Most got CVVH with the system that I mentioned. And only 3% ended up having the need for cardiac support at initiation. Many of these survived to come off of treatment, but certainly these were really, really sick babies. Only 32% survived to hospital discharge, and even lower percent, only 17% were alive at 1 year. There's now a registry for children who are receiving aqueducts that's being led by Michelle Starr and others, and you can see there the centers that are currently participating. So if we go back to the future once again, I want to bring you back to this first baby in 1985 from that was dialyzed in Italy. In 2013, Claudio Ronco and his team took care of another baby, this time with a dedicated machine called the Carpe Diem, and they published their report in the Lancet back in 2013. If you're interested in reading a really interesting book about Dr. Claudio Ronco and his story about designing and what happened to this baby and his trials and tribulations through this time, this is a great read called the Carpe Diem book that you could find on Amazon or whatever. The really interesting part about this machine is that it's got lots of bells and whistles that are designed from the ground up to be for neonates. The accuracies are very accurate. The ability to calibrate and choose different blood flows is excellent. And the blood pumps have a very unique property in that they have 3-pronged approach, giving less swing on your peaks and troughs of your pressures, thus allowing a higher blood flow for a given access size. One thing to note about this machine is that you do need a dedicated bag of fluid that must be used for the Carpe Diem. It's a 2-liter bag. They currently only have one flavor that does have some potassium and calcium in the bag. This is the European experience by Vidal of the first 13 patients. And recently, Stu Goldstein kind of published this paper where he compared the patients that received Carpe Diem to the retrospective registry of those that had PPCRT. And you can see here that compared to the PPCRT registry, there was a huge number of patients that were able to come off therapy and do well. And then the overall survival seemed to be better compared to the PPCRT registry from a couple decades past. There's also a registry currently being performed. 17 sites are participating in the United States to do QI and research called the Iconic Registry, and that is coming soon to you. And so to compare Aqueduct and Carpe Diem, they have similar extracorporeal volume. Aqueduct could be done CVVH or just ultrafiltration. Carpe Diem, you could do dialysis or replacement, but not both, or just ultrafiltration. Again, similar extracorporeal volumes. Blood flows can be 10 to 40 versus 2 to 50. Here you can calibrate by 1s in the Carpe Diem, by 5s in the Aqueducts. Ultrafiltration is similar. You can calibrate by 1s in carpe diem versus by 10s in ultrafiltration. The accuracy is more precise in the carpe diem. And the prescription is per hour in Aquadex. It's per treatment in carpe diem, so you have to kind of figure out how many hours you're going to do the therapy. The max duration of therapy in the Aquadex is 72 hours versus 24 hours that you have to change out the circuit in the carpe diem. The Aquadex has a hematocrit light and an SVO2 monitor, and the bags that you could use for replacement in Aquadex are any bags you have available, whereas you have to use the 1K 3.5 calcium bag in the carpe diem. The Newcastle machine has been out there. It's a single lumen catheter, uses syringes, and again, I mentioned that the iKid study has been published. I don't have time to go in great detail into the prescription. I do think it's important to mention that you got to get your axis right, and you got to think about blood priming and when and how you blood prime to do CRT well in neonates. And again, unfortunately, I don't have time to go into great detail on those, but I can certainly field any questions offline about that. And then the final thing that I was going to add is that we have now put together a course called the NICS course. It's quarterly. We've been doing it through Zoom. Our next one's in May 23rd of 2022, so in about a month or so. If you're interested, we spend a day and a half going through the entire prescription, access education, medications, and multiple other aspects of care on not only PD, but also details about Aquadex, Carpe Diem, and the HF20. And remember, there's the 4th International Symposium on AKI in Children in Cincinnati. Please make efforts to be there at that one. So with that, I'm going to conclude and say that recent advances in technology have enhanced our ability to care for very sick and very tiny babies without the traditional challenges and complications we used to face. And the next decade will be exciting with education, program development, data on neonates who receive therapy, neonatal specific prescription guidelines, and advocacy for those with congenital kidney disease. And with that, I thank you for your time.